a loss. So I think that there tends to be a lot of pressure at some abortion clinics anyway in terms of pushing women toward these decisions. I'm involved as an expert in a legal case right now in Arizona where that's exactly the question. A 17-year-old who went in there obviously very conflicted about the abortion and basically kind of got tracked into this abortion, and subsequently bad things happened, and now there's a real argument about the consent that was obtained from this patient. Especially Arizona has a parental consent law that apparently was not followed. So these get to be very difficult questions along those lines. It's interesting, I mentioned this information I found out, this was actually a court case, kind of getting into that topic as an aside. I have the entire consent form. I read to you part about this removal of laminaria may cause infection and bleeding and all this other stuff. It was really interesting. There was also a notation here that, again, is really interesting. Twice on the same form, they reiterated the same thing. Removal of laminaria attends at the request of the patient and against medical advice may lead to bleeding, cramping, fever, spontaneous abortion, and other minor major medical complications for which hospitalization may be required. And I thought this was interesting. Refunds to the patient at the time of laminaria removal will not exceed 20% of the collected fee. So if you want your laminaria out, we'll do it, but you're only going to get 20% of your money back. It's kind of interesting, for not even having done the procedure. Any other questions? Go ahead.
I believe for me this is really very painful, and the professionals, when they perform this, how do they feel? What's their experience when they take out the law?
How do professionals feel when they perform abortions?
That's right.
If you're pro-choice like I was, you feel, well, this is a woman's choice. I'm helping her make her choice. I'm being a good doctor by helping her with her problem pregnancy, and I'm doing a good thing. That's part of what somebody who does abortions feel, at least what I felt. I can only speak for myself. I will tell you the first time that, even though I had done hundreds of first trimester abortions, at the time I started doing second trimester abortions, that didn't feel so good. I mean, a second trimester abortion is not just putting in a suction catheter and spinning it around and doing a scrape. You have to use a grasping clamp. I should have brought my instruments. They're sitting in my luggage. A grasping clamp, a sofa clamp, for instance, a large, heavy grasping clamp, and you have to pull limbs off of a living human being. That's not so simple. That was pretty difficult the first time I did it. Unfortunately, I got used to it. You can get used to just about anything.
So how do we say pro-choice if we're taking life? How do we say pro-choice? There's no choice. The baby doesn't have any choice.
Baby has no choice at all. The choice that's involved is only the woman's. Not even the father has a choice. That's what we've constructed in our country. If you're asking me to defend the other side, I'm going to have a hard time doing it, but I'll do my best. Go ahead.
Is there any knowledge about frequency of the occurrence of the woman changing her mind at the point when...
I have never seen somebody actually, I mean, to really determine that, you need a large-scale study with a lot of patients to get some idea of what those numbers were like. I'm not even sure where you would conduct such a study. I have never seen anything that documents that. In my experience, 1,200 abortions in private practice, I got to tell you, the number of people that changed their minds was a handful. I'd say less than 20. So at least in my practice, that was an unusual occurrence. Now, on the other hand, I'll blow my horn a little bit. Again, I wasn't running an abortion clinic. I didn't have to pressure my patients either way. I was perfectly happy to have her make any choice she wished to make. We were very careful in counseling patients. Our patients were extensively counseled before we would initiate an abortion procedure, in terms of why they were there, what their reasons were, did they have any questions, and are you sure this is what you want to do? Again, I was perfectly happy if she chose not to have the abortion. And I'm sure there were, I can't give you specific numbers, we're talking a long time ago, but I'm sure there were plenty of people that once they got through the counseling said, you know what, maybe I'm not going to do this. It depends, I suppose, a lot on how, where she's getting this abortion performed. Is it a clinic? How many do they do? What kind of pressures is she feeling? My experience, at least in my practice, with the numbers that actually change your mind are pretty small.
In your experience and where you're practicing, is this typically an emergency department kind of stop in, have the luminary removed and back to the clinic, or is this better performed by an obstetrician, in a time frame that would allow for appropriate removal? But I mean, I'm not hearing it has to be done now because 15 minutes later there is
No. This is an emergent situation when somebody walks in the emergency room and says, I want these removed. No, I don't think it's particularly emergent. I mean, it's urgent. You don't want her sitting around hour after hour after hour. There's an advantage to removing them as soon as you can. But it is not a situation where an emergency physician has to feel like, oh my God, I got to get this done like now. I mean, in my hospital, gosh, the emergency physicians wouldn't even pull IUDs, much less laminaria. So I'd get the call, and it was appropriate. Like, could you come down here and pull the IUD out? It's like, oh, come on. You know, it takes 2 seconds, but okay. No, call your OBGYN residents, get them down to do it. I mean, I don't think it's something an emergency room physician needs to feel obligated to do. But I would certainly, if you have OBGYN support, have them do the procedure. I think that's appropriate. And no, it's not an oh my God, 911 emergency that has to be done in the next 5 minutes. Not at all.
Just one more thing. So once the laminaria is removed, then how long is it till the cervix actually closes completely?
Depends on how dilated it is. These studies quote up to a week. These were widely dilated cervixes, and I said several centimeters. But they will return. Will return over time. There's no set time. Depends on how far it's dilated already.
But you said no real change to her activity level.
I would, as I said, I would put her on antibiotics. Ampicillin plus flagyl, cephalosporin plus flagyl for 7 days. I would suggest bed rest for 48 hours. As I said, just to feel that I've done everything I can. No heavy lifting. Again, for 48 hours at least. There are no set guidelines, but they just seem like common sense precautions to me.
Do you think this requires an admission into the hospital, or is this something that could be done in the emergency department by?
Lord, no.
No,
No admission would be needed. Call your OBGYN resident or do it yourself if you're feeling brave. Put them on antibiotics, give them instructions to go home, take it easy, but there's no reason for admission. Again, unless bleeding, if you've got suspicion of an impending miscarriage or an infection, that's a different story. But if you've got a normal, white count, if there's no evidence of bleeding, she's non-tender, no evidence of miscarriage, there's no reason she can't go home. There's no benefit to being in the hospital, other than forcing them to stay in a bed.